L'osteoporosi può presentarsi con gravità diverse, da forme di entità media a forme invece molto più gravi, nelle quali l'insorgenza di una frattura da fragilità è, come si dice, imminente. L'approccio dunque non può essere lo stesso e su questi temi la professoressa Bente Langdahl, che abbiamo incontrato qui a Bari al 22° congresso nazionale della Siommms, ha delle idee abbastanza diverse rispetto a quello che invece è l'approccio tradizionale. Ne abbiamo parlato con lei per farci spiegare qual è invece la strategia che lei propone. First of all, which are the challenges of current guidelines in the treatment of osteoporosis? Which are the gray zones?
I think the biggest challenge is that most of the guidelines actually, they do a lot of work in the guidelines about how to group people into to patients with low risk and high risk. But when it comes to assigning treatment to these different groups of patients, they are very reluctant to actually say this group of patients should have this type of treatment and this group should maybe have this. It's kind of, they just list all the treatments and then it's just in the end up to the individual.
So it's difficult for the clinician to decide which is the best drug for this specific patient.
I think it's difficult for the clinician to figure out exactly what type of patient should I consider using the most effective, the bone building treatments, and which patients will it be okay to use anti-remodeling treatments, which of course has been here for many, many years. It's cheaper and they're also good drugs. But we have some patients with very serious and severe osteoporosis that need bone building treatment to actually really reduce their risk of fractures in the future.
In Italy, there are strictly rules of pharma authority, which his name is IFA, regarding the prescription of the drug. I don't know if in Denmark it's different, but here you cannot prescribe everything to everybody. You have to use the drug respecting, first of all, the indication, and second, the reimbursement rules of the drug. Yeah. Is different in Denmark?
No, it's the same. I think it's the same in most parts of the world. But these rules and guidelines by the authorities, they are coming from somewhere. And I think we need to challenge the authorities, say, we appreciate that you want to, do this cost effective. And so we need to show that it can be cost effective to actually use a more expensive drug for a patient with very severe disease. And we need to use them in the right order because there's a lot of evidence that you get the most out of the bone building drugs if you use them as first line treatment, whereas you only get a limited increase in BMD if you use them after an anti-resorptive. So I think my purpose with this talk is actually to start having people talk about this and then approach the authorities and say, hey, we need to talk about this because this is not the optimal way of treating osteoporosis with the knowledge we have today. This is 10 years outdated.
So your approach is to use bone building drugs earlier in the story of the patient.
Yeah. I think we have pretty good evidence from all the trials with the bone building therapies, so that would be teriparatide and romosozumab, that you get the biggest increase in BMD and very strong and very rapid decrease in fracture risk if you use these drugs as first-line treatment. So I think not for everybody, but for the patients at high risk, I think that is what we and the authorities should recognize and start thinking about. Maybe that is the best approach.
Since very recently, the only bone building drug almost in our country was teriparatide, and now we have also romosozumab, so there is a second choice. There are differences in your point of view between these two drugs in your approach?
Yeah, of course, they have not been compared head to head in treatment naive patients. They have been in patients previously treated with bisphosphonate, and there you get a bigger increase in BMD with romosozumab. So in my mind, romosozumab is a superior bone forming treatment compared to teriparatide. So that would be my preference. If, of course, there are some adverse events or some contraindications you need to take into account. So, but if in a patient without cardiovascular disease, you can only give it to women, that would be my preferred choice there.